Hi, I'm Marie-France Poland, and live at SCAI 2019, and I'm joined today by Eric Horlick, and we're going to talk about the new PFO Operator Requirement.
Thank you.
All right, so can you tell us why was there a need for that document?
So there's just under 800,000 strokes per year in the United States, and those actually have a huge societal cost, about $34 billion. About 87% of those are ischemic strokes, and of those about 40% or up to 40% are related to cryptogenic stroke. And when you think about the fact that about 25% of patients have a PFO, it becomes a really important problem for us to get right.
So can you tell us a little bit more about the history of the PFO approval in the United States?
Sure. So in 2017, there were two devices approved. 2017, 2018, two devices were approved. The Abbott PFO occluder and the Gore septal occluder were both approved for PFO closure. And before that, the devices were available on a humanitarian device exemption, and a limited number of patients were supposed to be treated in the United States, less than 4,000. And of course, that got a little bit more than that number, and the FDA asked for a voluntary recall of that humanitarian device exemption, and that really spurred enrollment into the trials, and now we have very high quality evidence to suggest that PFO closure in properly investigated patients with cryptogenic stroke benefit from closure as opposed to medical therapy to treat the condition.
For really good trials, right?
That's right.
Yeah. All right. So in the PFO Operator Requirement document, what are the main key points?
I think there are a lot of nice things in that document. First of all is to really put the stroke neurologist really at the center of the investigation, and to really partner with our neurology colleagues. And in fact, the American Academy of Neurology affirmed the value of this statement, and the writing group was composed of both cardiologists and neurologists.
That's very important.
I think it's very important. We laid out some very specific recommendations for the number of cases operators should perform to be credentialed in the procedure, and also what institution should have and what program should have, and what was appropriate that we felt as an expert writing group was appropriate for them to have in order to perform their procedure with a high degree of safety and high quality.
And was there any specific numbers of procedures related to PFO occlusion?
Sure.
In the document? Sorry.
So we'd like the operators to have 50 lifetime structural heart disease procedures with at least 25 septal-based procedures or 15 12 PFO procedures. And then for ongoing maintenance, we'd like them to have 30 procedures, of which 30 septal procedures, with at least 15 being PFO procedures for ongoing credentialing. And for novice operators, we'd like them to have at least 10 cases proctored by an experienced physician with a peer-to-peer training program in place prior to that, to make sure that all of the knowledge that's required to perform the procedure is actually present.
Very good. And coming back also to the role of the neurologist being involved in the patient selection, can you tell us a little bit more about why you thought it was that important to have them involved?
Sure. I mean, I think that, as Steve Messe just said in our PFO session, every stroke starts out as cryptogenic before they're investigated. That's true. So it's really very important to actually have a complete and thorough investigation with someone with expertise in stroke. So our preference is always a vascular trained neurologist, but unfortunately in the United States there are inadequate numbers to cover the whole country. And so really what we said is it's really important to have a neurologist who has an interest and training in stroke. So not every neurologist is going to have specific vascular fellowship, but we really wanted someone who has an interest and a practice in stroke for certain.
That's good. And that's to ensure proper patient selection and good outcomes.
Absolutely, because it's like anything. It's garbage in, garbage out. So if you close someone's PFO who has atrial fibrillation and you didn't know about it because you didn't look, well, guess what? I mean, they're going to have an event, and that's not going to be related to their PFO, and they'll have had a procedure for really not the right indication.
Okay. Is there any mention in the document about the duration of atrial fibrillation monitoring that you do, or that you recommend that we do?
I really think that that's something in evolution. I mean, clearly there's a few trials that are published in the New England Journal of Medicine in 2014, one with implantable devices in patients over 40, and another 1 month of monitoring patients over the age of 55. Both of them showed more events the longer you monitor. I think it's still a moving target in terms of the duration, and for example, does a 25-year-old need 4 weeks of Holter monitoring? I think that's kind of still up in the air.
Very good, very good.
Yeah.
So is there anything in the document that's going to change the way, or you think is going to change the way that we as operators practice in the country?
I think that interventional cardiologists and institutions will look at this as a base to inform the way they carry out their daily work. And I hope it will be something that will spur quality initiatives around the country. And I think for operators, I mean, I think nobody wants to really be in contravention of guidelines. But if, I think these are goals that we can work to. I mean, I think it's hard when a new document comes out to actually everyone be 100% compliant. But I think really for the safety of the public and really to carry out the best quality work, I think these are very reasonable goals to attempt to attain.
Very good. All right. Well, Dr. Horlick, thank you very much.
Fantastic.
And keep following us live on SCAI 2019.
Thank you.